Good afternoon to this sixth episode of Ask Gunasheela series. We are doing a patient education series covering the various topics of reproductive medicine. Please note that this is a patient education series and it is not really targeted to the doctors. I am Dr. Devika Gunasheela and the director of Gunasheela Hospital, and with me is my very senior colleague, Dr. Raajam M, who will be talking to us about the drugs used in ovulation induction. And basically, I think we would need to go to our first slide and let us take you through this whole to understand ovulation induction. One should know what exactly is ovulation. And to understand ovulation, one should know what exactly constitutes a menstrual cycle. So I think Dr. Rajam will start off answering some of the questions. But this is a Facebook Live program, and at any time during the program, you can text in your questions to the program, or at other times you can write to ask@gunasheela.com, and we'll be very, very happy to answer them. So, Dr. Rajam, I just want you to tell me what exactly happens in a menstrual cycle. What are the various phases?
All healthy women have regular cycles with an average duration of about 28 to 30 days. And during each menstrual cycle, with the help of hormones from the brain, cyclical events take place in the ovary as well as the uterus. And these cyclical changes prepare a woman for a pregnancy.
Yeah.
The cyclical changes in the ovary and the uterus, they can be divided into 4 phases, which is a menstrual phase, a follicular phase, an ovulatory phase, and a luteal phase. During menstruation, you have bleeding, and at the end of bleeding, the follicular phase starts. Follicular phase is a phase where eggs inside the follicles, eggs inside water bubbles, they are called follicles. The follicles.
See, the thing is that we can't actually see the eggs. Is that correct?
Yes, yes.
Neither through ultrasound nor through the naked eye. So what we depend upon is what we call as a follicle, which is a water-filled bubble containing the egg. So when you come for scans, when anybody comes for a scan, what we look at in the ovaries are these follicles. So they're an indirect assessment of the egg. So in the follicular phase,
the follicles will grow. Yeah. Along with that, the egg inside them also will grow.
Yes, exactly.
So at the end of the follicular phase, the follicle will become a mature follicle with a mature egg inside.
Yeah.
And around the middle of the cycle, this follicle will burst, releasing that mature egg.
Under the control of certain hormones. Yeah.
So when it releases an egg, that is the time when the woman is fertile, so that she has to have an intercourse with her husband to for a pregnancy.
Yeah.
And once the follicle is ruptured and the ovum is released, the same follicle will become a structure called corpus luteum, which will secrete few hormones to support the pregnancy. So once the egg comes out and it meets the sperms, it will form a baby. The baby will go and sit inside the uterus. To support the baby in the uterus, the corpus luteum
will produce hormones like progesterone and things like that, and so that's how the pregnancy goes on. So the most important part is the ovulation that takes place. And can I have the next slide, please? So basically now what happens we have people coming in saying that we have irregular cycles, right?
Yes.
So if somebody is having a regular cycle, then when can they actually expect to produce the egg, which is that event is called as ovulation. Yes. So when do they actually expect to have the egg?
Usually it's in the middle of a cycle, between the 10th and the 20th day of a cycle, in a 30-day cycle. And in each cycle it's different. Sometimes you may Sometimes you may ovulate on the 12th day, sometimes you may ovulate on the 14th day, sometimes you may ovulate on the 16th day. So to cover the broader aspect, between the 10th and 20th day is the fertile period in a regularly cycling woman having 28 to 30 days cycle.
Yes.
But
So now, what is ovulation? What is the definition of ovulation? I mean, how would you tell somebody that okay, you're ovulating? And we have talked about the fertile period. So
hmm,
would you also want to talk about the vagaries of which phase is the constant phase?
hmm,
And there are
hmm,
certain vagaries in the menstrual cycle. So everybody's menstrual cycle is not the same. Some people do come and say that okay, we have every 28 days we have a period, which is excellent. It's like clockwork. But majority of the women do not have a menstrual cycle like that. It may be 28 days, it may be 35 days. So the normal menstrual cycle is anywhere between
21 and 35 days.
yeah.
And in a 21 in a woman cycling at 21 days, her ovulation will happen little early, maybe on the 7th or 8th day.
Yeah.
And in a woman who's cycling in 35 days, her ovulation may be happening a little late,
Yeah,
maybe
maybe
on
the
the 20th
20th day or
or
22nd day.
22nd
Yeah,
day, like
yeah,
that.
yeah.
So the most constant phase of a menstrual cycle is the second half. The follicular phase differs according to the length of the women's cycle. If a
Yeah.
women's cycle is longer, the follicular phase is longer. The women's cycle is shorter, the follicular phase is shorter. The luteal phase remains same. What it means is when once ovulation happens, 14th day you are supposed to get your period.
Correct. Yeah.
So if you're not getting your period if you're not getting a regular period, or if you have irregular cycles, that indirectly says that you are not ovulating.
Yeah.
Because if you ovulate on the 14th day, you will get a period.
Yeah. Or you may be
Or if you
ovulating
yeah,
late. That is another thing. So
thing.
suppose you have
Or if
40.
you have become pregnant, you may not get any
Yeah, so
period.
basically, how it works is that the follicular phase, which is from the time that you actually have your period, right after ovulation, is a variable phase. It can be 20 days, it can be 14 days, like clockwork, or it can be 45 days. But usually, after one ovulates or after one produces the egg, that phase is pretty constant. So you get your period in about 15 days. So suppose you were having a 45-day cycle, you most probably are ovulating on your 29th or the 30th day. And if you have a 60-day cycle, you're ovulating on your 45th day. But the only problem here is that when you have irregular cycles, we do not know how to tell you when you're ovulating, how you can time your intercourse, and that
Whether
becomes a
you're
bit of a
ovulating or
problem.
not, that
Yes,
itself is.
that's another very good problem. So then that comes to a situation where we're going to talk about who are the people who may not ovulate.
Hmm. People who are overweight, people who are very thin, people who have very stressful, doing vigorous exercises,
Yes,
they may not ovulate regularly. And the most common cause of these people not ovulating regularly is the polycystic ovarian syndrome,
yes.
where you have irregular cycles. And in patients who have premature ovarian failure, like where they lose their ovarian reserve early in their life, they may not ovulate regularly. And women having thyroid or prolactin disorders may also not ovulate regularly.
Correct. So then are there are certain signs which will actually tell us when a person is ovulating. So what would those signs be? How can a woman detect that she's ovulating? And suppose she's trying for a
Mm.
pregnancy, when should she actually have the intercourse apart from just the shall we say numerical calculation of the dates? So when
The thing is, just before ovulation, your like sexual desire increases, and there is a thinning of cervical mucus. The mucus becomes very thin, watery, and it will be of a raw egg white consistency. And you will have an ovulation pain when you ovulate. When the follicle ruptures, you will have a mild pain in your lower abdomen.
you have
And
ovulation pain, yes, that is one very good point. Also, you have a lot of pelvic heaviness, right?
heaviness.
And also, how to kind of differentiate, look at cervical mucus. See, a lot of women come and say that they have discharge all the cycle, and I think it's very important for us to talk
Mm,
about this portion of the discharge here because um, you have 5 days of your period and or 6 days, and after which you're supposed to be a little dry. You're
mm,
not supposed to have too much of discharge, but as you're reaching your 10th level, suppose we're talking about women who have regular cycles. So as you're reaching the days that you are going to ovulate, like Dr. Rajan said, you will have egg white mucus, and you will also, the mucus is thin, and it is, and if you hold the mucus in your hand and you part your fingers, it is very stretchy,
Yes, ma'am.
and you will actually see that that feature, and that is something which indicates that you are very close to your ovulation, or you may just be ovulating around that time. So that is something that you need to look out, and that is a very easy way to actually detect where you're ovulating, and so that's an indication for you to have intercourse as well. And also, like Dr. Rajam said, you'll have some people do have pain and some people do have heaviness. Yeah,
Heaviness.
yeah.
And after ovulation, there will be a zero point 0.5 to 1 degree rise in temperature. So if you want to monitor the basal body temperature, you need a digital thermometer which will record 1/10 of a degree.
Mm.
And early morning, even before brushing teeth, you have to check the temperature and mark it daily. And after ovulation, you will find a small peak in the small rise in the 0.5 degree rise in the
Yeah, and also
temperature.
there may be a dip when you actually ovulate, but then this is a very subjective thing. You know, it's very difficult to actually keep a thermometer and keep monitoring, and you may just miss it, or you know, it is supposed to be taken as soon as you get
Yep.
up,
And if you
even before you
forget,
get out of the bed. You know,
mm,
you're not supposed to drink water, you're not supposed to rush to the bathroom, and if you forget and then you say, "Oh my God," you know, half an hour later you take it, the temperature is completely all messed up.
yes,
Yeah.
ma'am.
Yeah. So so any other way that, you know, if a patient comes to us, how else will they actually monitor? Yeah, oh yeah, we have some ovulation kits, is that correct?
Yes,
Yeah.
there are self-assessment tests, what we have just described about that, and there are some tests which can be done at home.
Yeah.
Okay, it is an urine test
Mm.
and a salivary test.
Okay.
Urine test, like it depends on the cycle, the length of the cycle, ma'am.
Yeah.
Like if you have a 26-day cycle, you have to check it little early. From the
Okay.
9th day, you test it,
Okay.
and the kits providers, they
Yeah.
give from when to start testing it.
Yeah.
Just any part of the day, just take the strip and dip it in urine for 5 seconds.
Okay.
And if you see two lines,
Then
then
it is
then you are
uh,
about to ovulate.
yeah,
It's not that you
correct.
have ovulated, you're about to ovulate. The next 48 hours is the period when you will ovulate. So you need to have intercourse during that time to increase your chances of pregnancy.
So if they come to us, what would we look at?
If they come to us for treatment, then we need to monitor their follicle growth. The follicle growth starts from day 3, where there will be no, all follicles will be less than 1 centimeter in size, and then slowly it starts developing. It will become more than 10 millimeter or 12, 13 millimeter in the middle of a cycle, and just before rupture, it will become about 2 centimeter size, like 1.8 to 2 centimeter size, when the follicle gives way and releases the egg, where it will shrink and reduce in
Yeah,
size.
and that's what you're showing them, that how the follicle is
Yeah,
breaking out and the egg is coming out, right? That's the
yes.
last a
Mm.
purple colored.
So that requires a lot of visits to the hospital to monitor.
Yeah.
That is the one.
Yeah, but then see, we have some people who give a classic history that, you know, before marriage there were, shall we say, 50 kgs. A woman is about 5 feet or 5 feet 1. She has 50 kgs, and after marriage, because of marital bliss, she has, you know, put on weight. She's put on about 15 kgs, and now she's become 65. So they come and tell us that when we came to the hospital, after, you know, before marriage, it was regular. You know, the periods were
Periods are
regular,
regular.
and now they have become irregular, and are finding it difficult to conceive. Although we've been trying continuously for the last 1.5 years or 2 years. So then, for a young couple who's been married for about, you know, a year, and you know that she is visibly, you know, she's put on about 10 kgs or 12 kgs from her being really lean, or 50 kgs, and come to 65, and now her periods have become regular, whereas when she was 50, it was
Regular.
regular. So what are you going to tell them?
So, like losing weight may improve your ovulation. Losing at least 5 to 10% of your body weight may increase your, may restore spontaneous ovulation and increase your chances of pregnancy. So, weight reduction is by a combination of diet and exercise. So, if you reduce 10 to 5 to 10% of your body weight, you may ovulate on your own
And
without
that
taking
is,
any medications.
yeah, and that is because that is because when you put on weight, what happens is that you actually will have a lot of hormonal changes that happen, And when you have hormonal changes that happen, that messes up the ovulatory cycle. Is that correct?
Yes, ma'am.
And so the answer is in the patient's description itself. She's saying that when she's lean, she gets periods. When she's put on weight, she doesn't get a period. So the simple way is to lose the weight. Yeah. So and so now, okay, you've done all that, and she's still not ovulating. So, so
Still
in
not
whom
sure.
would you actually suggest inducing ovulation? Inducing ovulation means we might have to help them out to a small extent to produce the eggs or to help them to produce eggs. So, who would be the candidates who would require that?
So as we said, like who are all having anovulatory cycles. Anovulatory cycles means they are not having ovulation. They are not having regular cycles.
Yes.
Having irregular cycles.
Correct.
And women with conditions like polycystic ovarian syndrome, or women with having less hormones in the body, they all require ovulation induction.
Yeah.
And sometimes in regularly cycling women also we do ovulation induction in our practice. That is to increase their chances of pregnancy.
Yeah. Yeah, but if they are, if they are, and also if they have had many years that they've been trying, and
they've been tried for many years
and nothing is happening, so we also want to kind of augment that a bit. Yeah. So a woman who, you have to have some prerequisites. So you have a woman who comes to us, a patient who comes to us, a lady who says, okay, I'm having problems getting pregnant, and so now I want to start off something, you must help me. And we do all these tests, and then she may or may not be ovulating, and she's been married for quite a few years. And so what will be the other one or two conditions that she requires or she has to fulfill before we can take her up for giving her medication to produce eggs?
So the three most common things which are required for getting pregnant is, one is sperm, egg, and the tubes.
Yes.
So since she has anovulatory disorder, then that egg is release of egg is a problem, which we
Yes.
are helping it out. And the second or third things are, they should have a normal semen analysis and they should have open tubes.
Yeah, the tube is very important because, as we have explained this in our previous videos, when I was talking with Dr. Ashwini, that the tube is a very important structure because it is the conduit. It transports the sperm towards the egg, and then the fertilization or the meeting of the sperm and the egg happens in the tube, and the whole embryo, that is the fertilized egg, which continues to become the embryo, comes back into the uterus. So that is a very important. Yeah. Now, can you tell us something about which are the main medications that are used for producing these eggs? And ovulation inductions means giving you medication to produce eggs, right?
Yes.
So which are the main categories of medications?
There are oral tablets and there are injectables also. Usually oral tablets are easy to take, so we start with oral tablets.
Yeah.
Like clomiphene and letrozole are the most commonly used oral tablets.
Yeah.
And there are injectables also, like human menopausal gonadotropins and HCGs.
Yeah, these are all going to more hormonal
yeah,
injections, right?
This, when the oral tablets fail and when they have tried enough, they are the last resort.
Yeah, and there we are trying to manipulate the hormones and trying to kind of see whether that will help you out. So, which is the most common drug that one would start off with, or which has been very used widely and has been in the market for a long time?
Clomiphene citrate is the one which has been used for a very long time. Clomiphene citrate is given in 50 milligrams with a starting dose of 50 milligram for 5 days, starting from the third day of the periods.
Yeah.
But whenever you take clomiphene for 5 days, starting from the day 3 to day 5 of your cycle, you need to know whether the ovulation is happening.
Yeah.
So to know whether ovulation is happening, either you can use a home ovulation predictor test, or you should come for a monitoring, like an ultrasound monitoring, to know whether the follicle is developing and releasing an egg.
Yeah. So, so sometimes we get women who have had, like, should we say, 10 years married, out of which the first 2-3 years they've been trying by themselves. In the next 4-5 years, they've continuously had clomiphene citrate. So is that wise? I mean,
no, usually 3 ovulatory cycles are sufficient, but up to 6 cycles we can
correct,
give,
yeah.
and it's Like if it's not working, it's not working, and we
Yeah.
have to move on.
Yeah, so about 80% will actually ovulate. That means they will actually produce an egg. And there are, of course, with clomiphene, there are you are trying to produce eggs for the patient. So instead of one egg, which would be the ideal situation, she may get two or three, in which case there is a higher chance of having what is called as a multiple pregnancy, which is twins or triplets or babies of a higher order. Is that correct?
Yes.
Right. Now, sorry. Now letrozole is a new drug that has
Yeah.
come out.
Mm.
So can you tell us something about it?
Letrozole is a drug which is used for, it's an anti-cancer medication,
Yeah.
but it can be also used for
It
ovulation
has
induction.
been licensed now. Yeah.
Licensed now to use for
Yeah.
ovulation induction. The typical dose is 2.5 to 5 milligram. This is also started from day 3 to day 5 of the cycle for a period of 5 days. The same principles apply, like we have to check whether they are ovulating by either a home prediction test or by coming for follicular monitoring and see whether they are ovulating. The advantage with letrose is the chances of multiple pregnancies are very less,
Less.
because it produces only one follicle. It is
Yes, better for
supposed
single follicular development. And yeah,
previously there has been
controversy.
controversy telling that letrose causes a lot of child like congenital abnormalities in babies, but recent research have told that there is no
Yeah,
such evidence.
and letrose has been in and out, but then right now I think it has been recommended by most of the bodies that it is the first line of drug to be used in people with polycystic ovaries. So that has also come out. So we are kind of pretty clear about letrose. It can be used and there should be no problem. And so what exactly do you mean by follicular monitoring, Dr. Rajam?
Follicular monitoring is like when you when a woman is menstruating on day 3, you see follicles which are very small in size, which are less than 1 centimeter in size, containing an immature egg.
Yeah.
So when you give these medications like clomiphene or letrose, and then again you see them, these follicles, one of these follicles or one or two of these follicles will grow to a size more than 1 centimeter, and they are followed up till they reach a size of about 1.8 or 2 centimeters.
Yeah, correct. So you kind of follicular monitoring is when you ask the patient to come back again and again and
yeah.
monitor the growth of the follicles with
Serial
scans
scans.
and serial scans, and then so the patient also knows that maybe the medication is working also.
or not working.
And it's important for us also to know. So when the follicle reaches about shall we say 2 centimeters or anywhere between more than 1.8 to 2 or 2.2, then what would one do normally?
The thing is, the follicles may rupture on their own.
Yeah.
But the thing is, to time the intercourse and to time if you're doing an intrauterine insemination, to time them, we usually give a injection called HCG, which will help the egg to mature as well as to follicle to rupture and release the egg.
Yeah.
And it happens exactly 36 hours after we give this injection, so that it can be used to time the intercourse also.
Yes, correct. So this now we are going into the realm of what happens when you come to us and how we would help you out and with these injectables, and how exactly we would monitor the cycle, because when patients come to us, they keep on saying, what are you going to do, what are you going to do? So this is how we actually look after them. Now so we have the oral drugs, which are the tablets, which are easy, and then we have the injectables. So do tell us about the injectables. And
injectables are at the last resort. Like few cycles of oral tablets have failed, and with oral tablets they are not able to conceive, or oral tablets are not causing, few may not ovulate with oral tablets. They may require gonadotropins to ovulate. So those kind of women with anovulatory cycles require gonadotropins. And also when you require multiple follicles to be developed, as in the case where they are going for an in vitro fertilization, those time also gonadotropins are used.
Yeah, so gonadotropins are basically hormonal injections, which are the basic hormones that we have in our body, the FSH and the LH, follicular stimulating hormone and the luteinizing hormone. Follicular stimulating hormone is produced in the first half of the cycle. Luteinizing hormone is produced later on. It is required to make the follicle or the water bubble burst and release the egg that it contains. And these are manufactured in different ways. And just to go very, very quickly about the history of gonadotropins. So gonads are the testis and the ovaries, which is where the sperm is produced and the egg is produced. So these are hormones that act on the gonads, right?
Yes.
So, when was the first? How was the history? How did they develop? Because it was a huge advancement in the field of reproductive medicine when they started to use gonadotropins.
The first gonadotropin was HCG in pregnant mare
Yeah.
or in pregnant women. Their urine will have this hormone called HCG, which is that ovulation trigger. That they used to separate it and use it as a
HCG is basically human chorionic gonadotropin.
That is the
Yeah.
first gonadotropin.
Yeah.
From pregnant mare or from pregnant women's urine, they used to separate, and they
Yes,
used
that
to
was
use
as early as 1930s.
30s.
And
And then they used to take from the, since these hormones are from the brain,
yeah,
they used to take from the brain of dead animals or dead cadavers.
Yeah.
Like,
but that was not the ideal thing, right?
Ideal
So
thing,
because
because it has got a lot of impurities.
impurities, and also it can transmit viral infections
Viral
as well. The slow
infections.
viruses are a risk with that. So
Then in 70s it came the menopausal women's urine.
Yeah, maybe late 60s and the 70s. Yeah, at that point in time, it was not seen in India. We didn't have it here. And I think it was very much in the West. And it was taken out from women who were menopausal. That means women who had stopped their periods. So in women who are more than 50 or 55, and when they reach the menopause, they have very high levels of both these FSH as well as LH. And so they were asked to kind of give the urine in large quantities, and from the urine these menopausal HMG, which is human menopausal gonadotropin, and your FSH was all extracted. But at that point of time, it was a very basic process, and it had a lot of impurities. So there were there were a lot of proteins as impurities, and so they did produce reactions. And as time progressed, they became purified, and then as technology improved, they became more purified, and now we have of course, we have highly purified gonadotropins, which are, shall we say, got a very small percentage of impurities. But we also have gonadotropins got it from the recombinant technology. Yeah,
recombinant technology like is from Chinese hamster ovary line, and they are more purified, and they have more batch to batch consistency.
Yeah,
and
so they're and
they are more potent also.
They are more potent, and they're outcomes are slightly more predictable,
more
right?
predictable,
because
and they are more effective.
Yeah, but having said that, all these gonadotropins have to be kept in very controlled temperatures. So when patients come and tell us that we'll take it home and we'll get it done somewhere else, we are very worried that the temperature chain, that is the cold, they should be kept in cold temperature. So the cold chain will be, shall we say, disrupted,
and so their potency also reduces.
Yes, exactly. So in which settings should we use these gonadotropins?
So it should be in a place where there is scan facility to look at the follicular growth, because multiple follicle formation are more common with gonadotropins. Instead of 1 or 2 follicles, they may produce more than 6 follicles. So you need to continuously monitor them. Every 2 or 3 days, there will be visits to the hospital where the fertility specialist scans them, look at the follicular growth, and adjust the medications. The medications can be increased or decreased depending on the response.
Right. So how are they given then?
They are also started from the day 3 to day 5 of the menstrual cycle, and initially they are given for 4 to 5 days, and then every 2 or 3 days they are adjusted.
Yeah, and the doses would depend, the amount that you're giving them depends upon many factors. It depends upon your scans, depends upon the patient's basic hormonal levels, and age, correct, their weight, their BMI. So lots of other things that we calculate. We just don't start on a standard protocol. So giving gonadotropins is a little bit more complicated than just giving medications. It cannot be taken at home. It cannot be taken, shall we say, it can be taken at home. I mean, there's no problem with that as long as you keep it in the cold chain. But then you cannot take it by yourself, and you cannot take it without being monitored. That is one of the very important things. So when you start giving gonadotropins to produce eggs and for the ovulation, then the patient visits to the hospital do become a little bit more frequent. They're always worried that if you have a gonadotropin, you're going to use up too many of the eggs.
So whatever the egg. Yeah. It is not like that. Actually they do not use up anything more than naturally which is released. The thing is like no, in a normal cycle, when one egg is getting released, many eggs are recruited. Recruited means they all come into the cycle, but they all die off. Only one becomes dominant and releases an egg. Many follicles get recruited, but only one follicle becomes dominant. Whichever die off, or whichever follicles they die off, they are rescued by these gonadotropins. Whichever they die off, they are also saved, and they are also grown into the dominant follicles. So it is not that we are not using up any of the extra eggs from a woman. It is which usually whatever eggs they die off, that are picked up by the, or that are saved by the gonadotropins, and they are made into big follicles.
Now, a lot of people are very skeptical about taking injections. So they have 101 doubts, which is very, very justified. And one of the main questions that comes up is, what are the risks of taking these injections? Because when you say injections, that means everybody is very worried. When you say tablets, everybody is,
Okay.
it's okay with taking tablets, it's easy. When you have to have injections, oh my God, what am I getting into? So what are really the side effects of?
The side effects may be, as we said, like there are 30% chance of getting a hyper response. They may produce many follicles, not one or two follicles, many follicles they may produce even when used at a lower dosage. So when you have many follicles, when all the follicles are fertilized by the sperm, then you have multiple pregnancy. It may be a simple twins, or it may be a higher order multiple pregnancy, like
That is the bit of a
triplets and
problem. Yeah.
quadruplets. And that's why monitoring is very, very important in a woman who is taking gonadotropins.
Yeah.
And when they produce more than 3 follicles, it is advisable to cancel the cycle if they are trying naturally.
If they're trying naturally, or they're having a small IUI or something, it's important. See, the thing is that it's very nice to have twins sitting, holding two people holding twins, or holding two babies, or in a pram having two babies and going down for a stroll. But it is a very difficult journey for the patient when they have twins, because there are of the multitude of problems that can actually happen. So we would like you to have one good baby, which is healthy and
Yeah.
nice, and a handful, and easy to manage for both you and for us.
The aim of the fertility specialist is a singleton live birth.
Yes. So, are there any long-term risks? So that's another question that I get asked very often. I'm sure you also get asked by a lot of patients. They're all worried about ovarian cancer, breast cancer, and things like that. So,
There is no long-term risk,
Yes.
because even this clomiphene and letrozole, they are used only for 5 days in a cycle.
yeah.
And
No, we're talking about the injectables.
even injectables, they have effect on that cycle in which they are used.
It's a
They don't-
short-term effect.
Yeah,
It's
it is a short-term effect for that cycle. They don't
Yeah.
have any long-term effects. They do not produce any congenital abnormalities in the baby's born, and they are not associated with an increased risk of any cancer, ovarian or breast.
And also not really, shall we say, birth defects in the children also.
No,
Right?
birth
No
defects,
birth
birth
defects.
defects in the children.
Yeah. Yeah. So now, we just put this in just to kind of show the differences in how we would use the gonadotropins when we are coming to an in vitro fertilization cycle, and what is the difference, which is a more invasive, intensive, expensive procedure when compared to an IUI, which is an intrauterine insemination cycle, which is where we want one follicle or max two. We would like one though. So you want to elaborate on that, Dr. Rajam?
So when you give injections, this gonadotropins for an IVF cycle, we want multiple eggs.
Yes.
We want about 8 to 10 eggs
In an IVF cycle.
in an IVF
Yes.
cycle. So intentionally we give higher doses, and intentionally we give more purified preparations to have a good effect. So there the aim is to produce multiple eggs, an average of about 8 to 10. In an IUI where you want to try naturally, in an IUI or in an ovulation induction where you try naturally, we want 1 or 2 follicles. If the more than 3 follicles come, then it's better to cancel the cycle. And so we give either tablets or very low dose gonadotropins, and they are not very costly injections. Like purified ones we will give. Urinary purified ones are used for ovulation induction for an IUI or for a natural trying. And ultrasound monitoring is more intense in an IVF cycle, where you almost daily they need to come for scans and
Or if not daily,
monitoring.
really 2 to 3 days,
Yes.
every 2 to 3 days. Whereas in an IUI cycle, you can actually say, okay, take these for about, shall we say, 5 6 days and come back. And
Mm.
then when we start on injections, sometimes we overlap tablets and injections. Sometimes we give the injections for about 5 6 days and ask them to come back. So really, an IUI cycle is a little bit, shall we say, we take it a little bit more easy, and so patient visits are decreased, and we don't really want too many follicles to come up, because we do not want you to have multiple pregnancies or high order multiple pregnancies, triplets and quadruplets and things like that. Whereas an IVF cycle is a completely different ball game, which which Dr. Jyoti and I will be talking to you in one of our next episodes. And anything that you want to say to just sum it up?
Um,
Ovulation is basically a situation. Yeah,
any women having irregular cycles,
yeah,
and if they're obese, it's better that they try to lose their weight and be in their
yes,
optimal weight by a combination of diet and exercising.
yeah.
Being in optimal weight helps to induce ovulation naturally, and when you come for any type of ovulation induction, you get more success also.
And also, you use a particular type of a treatment, it's not working, use it for 3 cycles, 5 cycles, maximum 6 cycles, then you have to move on.
Mm.
There is no point in continuing that same
Clomiphene
type of a
cycle
treat,
for
yeah,
20
for 20
cycles.
cycles, 24 cycles. And we have seen women like that, 24 cycles, of clomiphene citrate. It's not going to work. So you just need to kind of understand that there are other ways of inducing development of the egg, and quite often these are very, very small procedures, and we just have to do a few tests, like a semen test and a tube test, to make sure that you're doing all right, and then we are on. So just wanting to let you know, thank you for being with us today, and we are happy to take any questions at all if you have any. And if you do not have any questions at this point of time, you're welcome to write to us at ask@gunshila.com. So hopefully you'll join us the next Saturday at the same time between 1 and 2. And thank you very much for being with us.
Thank you. Thank you.